Hello, Bilal Jalil here with another video. We're going to talk about vasopressors and inotropes today. A vasopressor, by definition, as the term suggests, refers to a medication that is performing vasoconstriction. Some of these vasopressors that we described today in the talk do have either inotropic or vasodilatory effects. And so generally we group all of these medicines that raise blood pressure or increase cardiac output into vasopressors. The two places where you would think of using medications like these would be either in patients who are hypotensive with a mean arterial pressure less than 65 or have a low cardiac output state. The goal with using these medications would be to improve hemodynamics, but also be able to improve cardiac output as well as perfusion. Before we talk further about the use of vasopressors, it's important to understand the concept of cardiac output. Cardiac output refers to the amount of blood being pumped by the heart per minute and is measured in liters per minute. And this formula shows the relationship between cardiac output and stroke volume as well as heart rate, such that an increase in stroke volume or heart rate will result in an increase in cardiac output and vice versa. This relationship is very important because that relationship between stroke volume and heart rate is such that it keeps cardiac output constant by adjusting one parameter or the other in a state of shock. And so most patients you'll see in a state of shock will mount a tachycardia response unless they're on medications that suppress their heart rate. And stroke volume is usually the parameter that we can adjust to improve cardiac output and perfusion. And so thus it's very important to understand this relationship between stroke volume and heart rate to the cardiac output. The next concept to understand is systemic vascular resistance. This is calculated by the pressure difference between the systemic circuit, which is mean arterial pressure minus the right atrial pressure, divided by the cardiac output. And this establishes a relationship between systemic vascular resistance and cardiac output such that there's an inverse relationship. Anytime your systemic vascular resistance will increase, your cardiac output will decrease. So let's look at this concept in terms of the systemic circulation. This diagram shows both the pulmonary circuit and the systemic circuit, and we're mostly going to concentrate on the systemic circuit for this talk on how different vasopressors function. Let's start by talking about vasoconstrictors. Vasoconstrictors function by increasing systemic vascular resistance by causing vasoconstriction and potentially improve perfusion in patients who have a state of a very low SVR, such as distributive shock or septic shock. It's important to note that most vasoconstrictors that we use, that we'll talk about in just a little bit, will both cause arterial vasoconstriction as well as venous vasoconstriction. Contrasting this to vasodilators that have the exact opposite effect of vasoconstrictors, in which they decrease SVR and is helpful to increase cardiac output in patients who have a very high SVR state, such as cardiogenic shock. The last group of medicines are inotropes. Inotropes directly try to increase the contractility of the myocardium and try to increase cardiac output by directly increasing stroke volume. Most inotropes will also have a chronotropic effect by which they increase heart rate, and this can also result in an increased cardiac output. Now, obviously, gone are the days when we had pulmonary artery catheters in patients in the ICU routinely and were able to measure cardiac output, systemic vascular resistance, stroke volume, all those parameters. For the purposes of this talk, the only reason I discuss stroke volumes, SVR, cardiac output are for you to understand how these medications work and how the different states of shock will benefit from different vasopressors. The 6 medications I want to talk about today are norepinephrine, vasopressin, epinephrine, phenylephrine, dobutamine, and dopamine. And we're going to try to group these into inotropes, vasoconstrictors, or vasodilators. Obviously, some of these will have an overlap between inotropes and vasoconstriction, or inotropes and vasodilatation, and so we'll talk about these as we go along. Let's start off by talking about norepinephrine. Norepinephrine works both on alpha and beta receptors, and thus will cause both vasoconstriction and an inotropic effect. The degree of vasoconstriction is usually a lot more than the inotropic effect norepinephrine provides, but for this reason, it is considered the first-line vasopressor because you can use it both in distributive shock, such as septic shock, as well as cardiogenic shock. And so we'll group norepinephrine between the overlap of vasoconstrictors and inotropes. Next, let's talk about vasopressin. Vasopressin works on the V1 and V2 receptors, resulting in vasoconstriction. This is a medicine that also results in splanchnic vasoconstriction and can help patients in distributive shock. In fact, the Surviving Sepsis Guidelines recommend the use of vasopressin at a low dose to help get a synergistic effect to decrease the amount of norepinephrine a patient is requiring. The other utility for vasopressin is to treat patients with hepatorenal syndrome as a substitute for terlipressin, which is not available in the United States. It's important to remember that patients who are on both vasopressin and norepinephrine together are at risk for developing digital ischemia, and so there isn't much that can be done about digital ischemia apart from conservative and supportive care, but it's important to detect it early. And so make sure that you examine patients' fingers and toes every day to make sure that you can detect this. And so this would put vasopressin in the pure vasoconstrictors. Next, let's talk about epinephrine. Epinephrine works both on alpha and beta receptors, so will give you some vasoconstriction and an inotropic effect. It's important to remember that lower doses of epinephrine result in more inotropy, and the higher you go on your epinephrine doses, you will get more vasoconstriction. The two things to remember about epinephrine is one, it increases your risk of patients developing tachyarrhythmias, such as atrial fibrillation or atrial flutter, and it can also result in lactic acidosis. This is only important to remember so that clinicians are not chasing a lactic acid that may be related to epinephrine. It is actually considered beneficial to patients who are on epinephrine to develop a lactic acidosis. The tachycardia that's induced by epinephrine can actually sometimes be used for patients who are having bradyarrhythmias that may be causing hypotension. And so epinephrine's a good medicine to use in bradycardic shock, in distributive shock, as well as cardiac shock. And so we would put epinephrine in the overlap between vasoconstriction and inotropy. Now let's come to phenylephrine. Phenylephrine is a pure vasoconstrictor as it only works on alpha receptors. And it can cause a reflex bradycardia, so that's something to look out for. There's a very good use of phenylephrine in critical aortic stenosis because these patients need to maintain a gradient across the left ventricular outflow tract. And thus, phenylephrine can actually help in patients who have critical aortic stenosis who are hypotensive. In fact, it should be your pressor of choice in patients with critical aortic stenosis. It's also a very good pressor to use peripherally, as there are no reports on skin necrosis from extravasation of phenylephrine, and it also comes in a dilute solution, which may be the reason why that is the case. This would be a very good medicine to use in distributive shock. For bradycardic shock, obviously that side effect of reflex bradycardia makes it a no-no. And then in cardiogenic shock, you already have a very high SVR. Phenylephrine is going to only increase your SVR, so this would be a wrong choice to use in cardiogenic shock. And so we would group phenylephrine as a pure vasoconstrictor. Now let's come to dobutamine. Dobutamine only works on beta receptors and thus is a pure inotrope. It can cause some chronotropic effects because of the beta receptor stimulation. The one thing to know about dobutamine is that it can cause reflex hypotension because of a small decrease in SVR, and that can result in the reflex hypotension. That's something to look out for. The good thing about dobutamine is that it has a very short half-life, and so you can titrate it very easily. easily, in contrast to milrinone, which we'll talk about next. And so dobutamine is a very good medicine to use in cardiogenic shock. In septic shock, you may use it in patients who may have a mixed component of cardiogenic and septic shock. And so I would advise caution in using dobutamine in a patient with septic shock unless it's the appropriate patient for it. And so we would group dobutamine as a pure inotrope. Next, coming to milrinone. Milrinone is very, very similar to dobutamine. Obviously works in a very different way. It's a PDE3 inhibitor, and so it results in increased intracellular cyclic AMP levels. And this will both cause vasodilatation as well as inotropy. And the degree of vasodilatation is more than what you would get with dobutamine, and hence the reflex hypotension is a lot more common with milrinone than it is with dobutamine. It does have a much longer half-life, and it is renally cleared, so that's something to keep in mind in patients who are in renal failure or have chronic kidney disease. Very good medicine to use in cardiogenic shock. I would give the same advice for septic shock, that if you have a patient who has a mixed picture of both septic and cardiogenic shock, this may be a medicine you would use, but it would not be the first medicine. It would not be the primary medicine that I would use to elevate blood pressures in a patient with septic shock. A point I would like to mention at this point is that both dobutamine and milrinone, these are medicines that we're using primarily in cardiogenic shock, and these should not be medicines that we target to titrate by blood pressure. These are medicines that we should target to perfusion, whether that's cardiac output, whether that's stroke volume, whether that's urine output. Any of those parameters can help you track on how to titrate this medicine. And so we would group milrinone in the overlap between vasodilators and inotropes. The last medicine to talk about is dopamine, and I've left it for the last, one, because it's complicated, and two, because there is no routine use left in the ICUs anymore for dopamine, while we have other medicines that are much better to use. Dopamine works on the dopamine receptors, beta receptors, and alpha receptors, and it works in that continuum as you go up on doses. So at a lower dose, dopamine works on dopamine receptors, which are primarily resulting in a decrease in systemic vascular resistance, can cause a little hypotension. As you go to moderate doses, dopamine starts working on beta receptors and is more of an inotrope. And at higher doses of dopamine, it also works on alpha receptors and thus becomes a vasoconstrictor. And so dopamine can do different things depending on what dose of dopamine you are on. This does make it very hard to titrate because you really don't know what function dopamine is serving for your patient. It does have a chronotropic effect, and so that chronotropic effect is helpful in patients who are bradycardic, but it does put them at risk for tachyarrhythmias. There is also no antidote for dopamine if it extravasates, and so I would recommend against the use of peripheral dopamine. It is a good medicine to use in bradycardic shock and cardiogenic shock. You could make an argument that you could use epinephrine as opposed to dopamine for both of those purposes. It probably not the drug of choice for distributive shock. In fact, there are trials that have showed that dopamine increases mortality when used in septic shock. And so I would group this medicine in all three, as it does have all effects: vasodilatation, inotropy, and vasoconstriction. Just for the purposes of completing this diagram, I'm going to add nitroprusside. Nitroprusside, I want you to think about as having the exact opposite effect that phenylephrine has. And so it's a pure vasodilator that decreases SVR and can also be used as an agent in cardiogenic shock. And lastly, I just want to leave you with this table that kind of summarizes what medications you would use in different shock states. To simplify it, I've sorted it out into distributive shock, cardiogenic shock, and bradycardic shock. I've put norepinephrine in bold under distributive shock, as it is the agent of choice as a first-line pressor. Dobutamine bolded for cardiogenic shock. And epinephrine bolded for bradycardic shock. And those are my preferences as go-to vasoactive medications to use in these different shock states. You may also see some of these medications be used at fixed doses, such as low-dose epinephrine as an inotrope, or low-dose vasopressin as a synergistic medicine to use with Levophed. And so you may see combinations of these medicines being used. Specifically in distributive shock, this happens sometimes where patients are on norepinephrine and their requirements are escalating pretty rapidly. And so the sequence that I use to add other pressors on is I usually get to a moderate dose of Levophed. When I'm there, I'll add vasopressin and see if we can decrease the amount of norepinephrine they're on, and then later on add phenylephrine or epinephrine as a third pressor. And this brings us to the end of this video. Please do hit the like button if this video was helpful to you. Leave comments for feedback or for requesting new videos. And please do subscribe to this channel. Thank you.